And here I just will show you what we think goes on in autoimmunity. So everything starts not in the brain, but in this small organ, the thymus, which is basically the primary school for immune cells. What happens there is that these immune cells gets activated against foreign antigens. So every virus, bacteria, they should fight against them. And the ones which react with self-antigens like this one get destroyed so that we delete the autoreactive T cells. But then all of a sudden, like with this guy here, it may happen that even an autoreactive T cell gets activated, so falsely educated, leaves the thymus and then goes across the bloodstream. Look, these guys go through. They don't enter the brain. This one here stops but goes through. Here comes the bad guy again, the autoreactive T cell. He gets activated, gets through the blood-brain barrier into the central nervous system, and then it will attach to the myelin sheath. So this is the target structure, which is attacked by these autoreactive T cells. And then, if it recognizes this one here, it will release factors which are bad for myelin, bad for the axon. It will attract further inflammatory mediators, and you can see a whole army of soldiers arrive at the scene where they're not supposed to be. And then even here's the great guy, the so-called macrophage, who will chop up all the myelin, and this leads to severe symptoms. That's what happened in MS if you try to bring it down to the cellular or molecular level. And you all know that this is a kind of way you would like to describe in a more plastic and easy understandable way how we could interfere with this process, which is possible if we start with medication early on. But then again, it's not as simple as you always think. Inflammation is bad, treat inflammation, everything will go away. There is probably more than just one kind of inflammation. This equation, early inflammation equals late degeneration, is with a question mark at the end. It tells you that although we know this kind of inflammation will bring these inflammatory parameters, will lead to demyelination and even axonal damage, we have seen that inflammation can also carry some trophic factor into the brain. We know that remyelination goes on. And very recently, it was all data showing that inflammation can actually provoke stem cell proliferation, so endogenous repair mechanisms. So we have to really think about it in different terms, that there are different aspects of inflammation. Okay, this again, as an introduction to the therapeutic approach, will easily tell us that this is a team approach. And one of the major teams, or team sports in Germany, of course, is football or soccer, either way where you look at this, and there you define goals yourself. And I guess the very simple ones are, we would like to reduce the damage and enhance repair. But again, not all of this is readily available. We can reduce the damage if we start early on with treatment, and we're working pretty hard on having also drugs which may enhance repair. But again, this only works in an environment where these drugs are not only being used in clinical trials, but make then later on readily available to our patients. And then thanks again to some initiatives of the National MS Societies in conjunction with members of the European Parliament, it was possible to come up with a code of good practice, which is now signed by health ministers of the European Union, that we can use as advocate for claiming this should be available in our countries. And I just would like to quote that this sentence, bearing in mind the need beyond drug therapy to develop effective and properly resourced services in care for multiple sclerosis patients which address their complex and lifelong requirements, is very important to really make happen what we can achieve during clinical studies, that we can deliver it to our patients in a clinical practice. So the way to go is really a complex one. Like the situation I came across, then I did one of my first experience back in Canada, flying on this small plane as a co-pilot and looking at all these different instruments. Of course, I didn't know anything about it, but I know they need to be kept in check. And this is also the situation in the multimodal approach to treatment in MS. There's not just one thing we need to concentrate on. There are different things we need to consider. And one of the most important things is any kind of treatment delivery starts with the diagnosis. You have heard about that. It needs proper education. It needs amelioration of symptoms, because that's what you really cared about. We don't want to stabilize a deficit. We want to bring you back to a normal function and then try to stabilize that. And then, of course, this is related to the last point here. We may also go ahead with disease-modifying treatment. So coming back to my favorite sport, there is different players in this MS treatment league. And the different players, we always ask us the question, are the ones we have, can we make them a little better? Maybe by just putting them at different places of the field, or maybe we just do a little bit of changes. And that's what is actually going on. There are new drugs, particularly from the interferons, the so-called biosimilars, which take up the data which they had and try to have new beta interferons coming out of that, or having new formulation, which basically addresses the question of less side effects, better tolerability. Or we may ask, if we do a little bit more training, can we increase the dose and get them doing better by that? And right now, we do have the situation where we could define basic therapy as a need for patients who have a certain disease activity. And that means that there are relapses present, particularly at the early stage of the disease, that there is inflammatory activity, that one should start treatment as early as possible with either beta interferons or clatamine acetate. And there are others down there. It's just a collection of which are pointed out, which are so-called second-line therapy if the first one are not very well tolerated or if they're not available. We also have to take in consideration that the treatment for relapses needs to be in place, which is a high-dose steroid therapy, and under certain circumstances, if they fail to that also plasma separation therapy may be available. But along the line of treatment, if the basic therapy doesn't work, there's also an option of treatment escalation. But again, we have to realize that this has not been very well established in clinical trials. It's just an option we would like to go on if basic therapy fails, but we also need trials in assessing this under evidence-based conditions. And then we have another problem that with the basic players in that field, that patients tend to stop interferon treatment after a while. And there have been various studies looking at the factors which are associated with that. So one of them is, of course, fatigue. It's up here. But something which is important, perceived lack of efficacy. Perceived, not always proven, but it's very difficult to have a medication if you don't see an immediate effect. So that's something which is a major reason why patients tend to stop. And then there are others concerning flu-like or ejection reaction, which make them stopping therapy. But what is probably more important, what will happen after you stop therapy? And the problem really is that part of this cohort, which was done by my colleagues Helen Tremlett and Joël Auger in Vancouver, that 40% of them stop therapy at all. And that's really a critical issue. There may have been certain aspects with one or the other of the diseases, but then we should be in place to recommend other treatments to start with rather than just stopping, although the disease is ongoing.